Hi guys, welcome everyone to the Medit Farre. So now we will be discussing about the questions from emergency medicine. So I have listed three important topics. First one is shock, then we have sepsis, and then we have ARDS. All of these could be 10 or 5 mark questions. Now each of them individually are extremely vast topics, so I'm not going into the details for now because the primary objective is to prepare you for writing a 10 mark or a 20 mark answer and not answer MCQs. So I'll keep it subtle and succinct. Unfortunately, I do not have access to the comments today, so I may not be able to reply to your comments. So if there is something that you could not understand or there's something that you want to get clarified, please ping me on the Instagram. I will take some time, but definitely I'll reply it. Okay. So first question is shock. So what is shock? The question may go like this: define shock, classify shock, and describe management of shock. So most important part of this question is going to be the classification of shock. There's nothing much in the management. Okay, but let us first begin by defining the shock. So what is shock? Shock, the moment you say shock, you think of hypotension. So please remember, shock is not equal to hypotension or hypotension is not equal to shock. Shock can occur in presence of normal BP as well. So what is the definition of shock? Impaired tissue delivery of oxygen. Means the delivery of oxygen to the tissues is impaired. That's the most important point. Yes, the most common cause for impaired delivery of oxygen to the tissues is going to be circulatory failure, means hypotension or other circulatory failure, where circulatory system is not able to deliver the blood to tissues. So if I'm not delivering blood to tissues, then tissues are also not going to get oxygen, right? And then why will this cause a problem? So if there is impaired tissue delivery of oxygen, that will resulting in metabolic abnormalities. Metabolic abnormalities, organ dysfunction and death. Organ dysfunction and death. Now let us understand, why am I getting metabolic abnormalities? Why am I getting organ dysfunction and death? So let us understand the pathophysiology. Okay, regardless of the cause, whatever I'm discussing now applies to all cases of shock. So let us say I have shock. When I have shock, that means there is decreased tissue delivery of oxygen. So because of that, the cells at the level of tissue switch from aerobic metabolism to anaerobic. Because see, first of all, why do we need oxygen for the cells? To survive. You know, you all agree that cells need oxygen, but why do we need it? Because we want to extract energy from glucose in the form of ATPs. For that we need oxygen. So if I don't have sufficient oxygen delivered to the cells, then cells can't make sufficient ATPs. And ATPs are required for the cell survival, because if this is a cell, for it to just survive, not do any major activity, just to survive, it has to keep shuffling lot of substances between intracellular compartment to extra and extracellular compartment to intra. Like sometimes it has to pump out sodium, sometimes it has to pump in potassium, or vice versa. Then lot of amino acids, glucose, right? Then protein molecules, peptides, we need to exchange between the cell and extracellular environment. And not all of these transports are passive. There is active transport involved. And for active transport, I need to spend ATPs. So if I'm not making ATPs, how will I do that? And if I'm not able to do that as a cell, I will die, right? So oxygen is necessary. Now, if I don't give sufficient oxygen, there has to be a survival mode, right? Yes, cells have a survival mode. What is it? From aerobic metabolism, we will switch the cells to anaerobic metabolism. So if there is decreased tissue delivery of oxygen, there will be anaerobic metabolism. And when we do anaerobic metabolism, we will not be able to generate large quantities of ATPs. So this will result in decreased ATP production. We are not producing as many ATPs as we could produce in aerobic metabolism. Decreased ATPs leads to cell death, because ATP is required for cell survival. And once cells die, there will be organ dysfunction. And when there is organ dysfunction, it can lead to death of the individual, not just the cell. The whole individual will die when multiple organs fail. The second thing that aerobic metabolism and anaerobic metabolism is going to do is, the end product of anaerobic metabolism, in the aerobic metabolism, the end product of burning glucose is water and carbon dioxide. That carbon dioxide is what we exhale. But in anaerobic metabolism, it is going to be lactic acid or lactate. So it will lead to increased serum lactic acid level or lactate level, and that will lead to metabolic acidosis. And we know that this metabolic acidosis itself is harmful for the cellular metabolism. Why? Because in acidic pH, the enzymes and reactions that happen at a cell level, they fail. So they also contribute, metabolic acidosis also contribute to cell death, in like pushing the patient towards death per se, right? So this is a basic stroke pathophysiology, sorry, the shock pathophysiology. Now that we know why shock can lead to death, let's understand what determines the oxygen delivery to the tissues. How oxygen reaches the tissues. So let us understand the determinants of tissue oxygen delivery. This tissue oxygen delivery, we will generally abbreviate it as DO2. DO2 refers to delivery of oxygen to the tissues. So what decides it, right? So let us understand the whole spectrum. Now for the oxygen to be delivered to the tissues, the transport medium is blood. Yeah, I know, hemoglobin, roughly speaking, blood. So I need blood to deliver the oxygen to the tissues. This blood needs to have sufficient volume and it needs to have hemoglobin. Okay. Now let us say I have an individual who has normal blood volume, normal hemoglobin. That means the oxygen carrying capacity of the blood is now normal. Now this blood has to go to the right side of the heart because from the tissues, which the deoxygenated blood goes to the right heart. From the right heart, it has to get pumped to the lungs, right? How does it go to lungs? Through pulmonary artery, right? Through pulmonary artery. And what happens at the level of lungs? Oxygenation. Once the blood got oxygenated, from the lungs, it goes to the left heart. And what happens in left heart? Left heart receives this oxygenated blood, then ejects it. So ejection of the blood happens by left heart. And we know that every systole, the amount of blood ejected is called as stroke volume, and amount of blood ejected per minute, that is stroke volume into heart rate, is called as cardiac output. So we eject the cardiac output from the left side of the heart. So now the blood, oxygenated blood, is ejected by the heart, and now it is going to go to the tissues which utilize oxygen. They utilize oxygen. So this is the system that is responsible for a delivery of oxygen to the tissues. When anything in this pathway goes wrong, we can end up with shock. Like let us say my lungs are fine, they're able to oxygenate the blood. My left side of the heart is fine, it is able to eject the blood. My tissues are fine, they are able to utilize the oxygen, but I have insufficient blood volume. Then what will happen? The amount of blood going to the right heart will be less. When do I have insufficient blood volume? When I have hemorrhage, dehydration because of acute GE or polyuria. So less blood goes to the right heart, then less blood goes to the lungs, then less blood comes to the left heart, less blood gets ejected. So less blood comes to the tissues, so less oxygen is delivered to the tissues. This is what we call as hypovolemic shock, right? Now let us think about second circumstance. Let us say blood volume is fine, hemoglobin is fine. So the content of oxygen in the blood is going to be fine. The lungs are fine. So now I have properly oxygenated blood coming to the left side of the heart, but heart fails to eject. Its contraction force has come down. So cardiac output will be less. So less oxygen gets delivered to the tissues. Again, you have shock. So multiple things can go wrong, right? So then we understand that this is a concept, but can I put it in mathematical terms? What are the important determinants of tissue delivery of oxygen? Yes, it is usually cardiac output and oxygen content of blood into oxygen content of blood. So CO stands for cardiac output and CaO2 stands for oxygen content of blood. Content of blood. Okay. Now this oxygen content of blood depends on what are the important determinants of this, how much oxygen is there in the blood. It depends on two parameters. The first one is going to be, of course, hemoglobin. So if I have less hemoglobin in blood, I will have less oxygen content. Second, how much of the hemoglobin molecules are saturated by oxygen, that is SpO2, right? The oxygenation is the job of lungs. So if lungs fail, SpO2 will be less, we know that. So anytime I have low hemoglobin or low SpO2, tissue delivery of oxygen may be low and I may be having shock. Then cardiac output, right? So what are the determinants of cardiac output? We define cardiac output as, how do we define? Cardiac output is stroke volume into heart rate. So any condition where there is decreased stroke volume or decreased heart rate, I can have low cardiac output. Low cardiac output means low tissue delivery of oxygen, right? Now I also want you to know that stroke volume is directly proportionate to preload. What do I mean by preload? The amount of blood present in the ventricles at the end of diastole. Means diastole is over. I have given blood to the ventricle. This is the blood that ventricle is capable of ejecting. It can't make its own blood. Whatever blood has reached the ventricle in diastole is the one that it can eject. So that is end diastolic volume, and that volume is what we call as preload. And another important determinant, okay, let us say that this is the left ventricle I am looking at. So in this left ventricle, I have added 100 ml of blood. Okay, that is at the end of diastole. I have transferred blood from the atria during diastole. At the end of diastole, 100 ml of blood is there in the ventricle. Now I want to eject it to the aorta. Whether I will be able to eject 20 ml out of this 100, 50 ml out of this 100, 70 ml out of this 100, that will be decided by the force of contraction of the left ventricle. So second determinant is going to be contractility. Contractility. And then once the preload or blood has reached the ventricle and ventricle contracts with sufficient force, it ejects the blood, but this blood now encounters a resistance by the aorta and its branches. So there is more resistance, then less amount of blood can be pushed into the aorta. Less resistance, more can be pushed. So we'll call this as systemic vascular resistance or peripheral vascular resistance, and it will have an inverse relationship with stroke volume. More resistance by aorta, less stroke volume. Less resistance by aorta, more stroke volume, right? Okay. So this is the determinants. These are the determinants of stroke volume. So can I say that the major determinants of tissue delivery of oxygen, right? So thus we can say determinants of DO2. One, oxygen content of blood. Oxygen content of blood. Second one is cardiac output. And the determinants of this oxygen content of blood are hemoglobin and SpO2. And determinants of cardiac output are stroke volume. Stroke volume is dependent on preload, contractility, and systemic vascular resistance. Second determinant is heart rate. So if I have bradycardia, I will have low cardiac output, right? So now that we have understood this, let us understand different types of shock. So we will classify shock into four broad categories. The first and the most common form of shock that we encounter in our clinical practice is going to be hypovolemic shock. Hypovolemic shock. So what happens in hypovolemic shock? In hypovolemic shock, like you had either hemorrhage or you had gastrointestinal blood loss or you had renal loss of fluid. GI loss can be also fluid loss like in acute gastroenteritis, or you have renal loss of fluid as in case of diuretic abuse or polyuria cases. In all these cases, what happens? I have lost fluid or blood from the body, so that results in decreased circulating blood volume. And when I have decreased circulating blood volume, what it will lead to? Decreased circulating blood volume will lead to decreased amount of blood reaching the heart. See, you just look at this continuum. So the blood volume decreased. So less blood reached right atrium, less blood reached the lungs, less blood reached the left heart. So the blood present in the ventricle for ejection by the left side of the heart is less. That means preload is less. So I have less blood, I can eject less only. That's why you have low cardiac output. So this will result in decreased preload, and decreased preload will result in decreased cardiac output, because decreased preload results in decreased stroke volume, and decreased cardiac output will result in decreased tissue delivery of oxygen, and that is what we call as shock. Right? Okay. Now in these patients, if I check their CVP, what will happen to the CVP? In these hypovolemic shock patients, what will happen to the CVP? So if I have to hemodynamically monitor a case of shock, we will look at CVP, pulmonary capillary wedge pressure. Okay. Then cardiac output and systemic vascular resistance. So if I'm talking about hypovolemic, so in hypovolemic, circulating blood volume is less, and we know that CVP or JVP, it correlates with the circulating blood volume. So if the blood volume is less, CVP will be low, right? And we know that in hypovolemic shock, we have developed decreased cardiac output. So you will have low cardiac output. And when the cardiac output decreases, what will happen to the BP? So you might know that systolic BP is directly proportionate to stroke volume. SVP is directly proportionate to stroke volume. So if stroke volume decreases, systolic BP decreases. So here we have decrease in systolic BP. And to counter this decreased systolic BP, we will have activation of RAS, renin-angiotensin-aldosterone axis, and sympathetic nervous system. Both of them, as we know, they cause vasoconstriction. They cause vasoconstriction. And because they cause vasoconstriction, they will lead to increase in, see, once the blood vessels, peripheral blood vessels are constricted, they will give more resistance to the flow of blood. That's what we call as peripheral or systemic vascular resistance, which is increased. So you have increased systemic vascular resistance. Okay. This is hypovolemic shock. Okay. The second shock that we are going to talk about is cardiogenic. These are second most common cause. The other forms of shock we will discuss later. Cardiogenic shock. So what happens in cardiogenic shock? In a cardiogenic shock, the cardiac output is low because of the problem with the heart, not because of the problem with the blood volume. Blood volume is fine, but this heart is still not able to produce sufficient cardiac output. What could be the reason? Cardiac output formula is stroke volume into heart rate. Either stroke volume is low or heart rate is low. That's why the cardiac output is less. And this low stroke volume is not because of hypovolemic. So what could be the reason? A classical example for cardiogenic shock is MI or ventricular fibrillation, or even very rapid ventricular tachycardia. Another example is complete heart block or bradyarrhythmias. Okay. So let us first understand complete heart block. So when there is complete heart block, there is decreased heart rate. And when heart rate decreases, we know that cardiac output is stroke volume into heart rate. So you will have decrease in cardiac output. And once the cardiac output decreases, there will be decreased tissue delivery of oxygen, and thus you have shock. And as we already know, the decreased cardiac output will lead to activation of RAS and sympathetic nervous system, and that will cause vasoconstriction. And because that is going to cause vasoconstriction, you will have increase in systemic vascular resistance. Okay. Second, let us say I have MI. So if I develop myocardial infarction, so if this is the heart that we are looking at, left side of the heart, and this lateral wall got MI. Now this myocardium is dead. Can it contract and eject the blood? No. Only the anterior wall and the interventricular septum is going to be contracting. The lateral wall won't contract. So even when I have sufficient preload in the heart, the force of contraction generated is less, so I will be able to eject only less quantity of blood. And if I express it in mathematical terms, we call it as ejection fraction. Ejection fraction is coming down. So in MI and ventricular fibrillation, there is decreased contractility. And because of decreased contractility, there will be decrease in stroke volume. Decreased stroke volume means decreased cardiac output. And decreased cardiac output means decreased tissue delivery of oxygen. And if there is decreased tissue delivery of oxygen, you have shock. And to counter this low cardiac output, RAS and sympathetic nervous system will get activated. You will have increase in systemic vascular resistance. So in cardiogenic shock also, you have decreased cardiac output and increased systemic vascular resistance. Okay. So then, so far parameters look same, right? What will happen to CVP? CVP depends on volume status as well as the right heart status. So if there is low volume, even in a patient with cardiogenic shock, CVP can be low. If the volume status is normal and right side of the heart is not affected, CVP can be normal. And if there is also involvement of right heart, not only left heart, then you will have increased CVP as well. So CVP may be normal, decreased or increased depending on other parameters. CVP doesn't hold a clue for diagnosis here. What holds the clue for diagnosis here is pulmonary capillary wedge pressure. Now you may be wondering, what is this pulmonary capillary wedge pressure? So we know that right heart receives the blood which is deoxygenated and then ejects to the pulmonary artery, right? And from the pulmonary artery, this blood goes to the lungs at the level of alveoli, and around this alveoli we have pulmonary capillaries. From these pulmonary capillaries, pulmonary veins take that oxygenated blood to the left side of the heart. Whenever I have left heart dysfunction, be it valvular heart disease or left ventricular failure or MI or arrhythmias, the left ventricle is not able to eject the blood. So more blood stays in the left ventricle. So because of that, left ventricular pressure increases. And if the LV pressure increases, behind that left atrial pressure increases, behind that pulmonary vein pressure increases, behind that pulmonary capillary pressure increases. Now I cannot directly put a catheter into the pulmonary capillary, but I can go closer to it and measure the pressure. That's what we call as pulmonary capillary wedge pressure. Indirectly, it's a pressure of pulmonary capillaries. So when it increases, whenever pressures in the left side of the heart are high. So that means in cardiogenic shock patients, you will have increased pulmonary capillary wedge pressure. But that is normal in hypovolemic, because in hypovolemic, the amount of blood reaching the right heart was less, so amount of blood reaching the left heart was less, so that's why less blood was ejected by left heart. Here, amount of blood reaching the right heart is normal, right? So blood volume is normal, but still because of some problem in the heart, it is not able to eject. That's cardiogenic shock. Now, we have two more types of shocks. One more is called as obstructive shock. And the last one is distributive shock. So what happens in obstructive shock? Obstructive shock refers to conditions where there is impairment of blood entry into the heart, from where blood enters into the heart from the superior vena cava and inferior vena cava. Blood enters the heart. So if I have created an obstruction for the blood to enter, see, blood volume is normal, but that blood is not able to make its way into the heart. When that can happen? What if I have a massive pericardial effusion causing the collapse of right ventricle? This ventricle gets collapsed. So then I can't fill this because it's already collapsed. So if I'm not able to fill sufficient blood in the right ventricle, from where it will eject? It is not getting filled. So it can't eject well. So if it is not ejecting well, then left heart receives less blood, left heart ejects less blood. And what do we call this condition? Cardiac tamponade, right? Same thing can happen in tension pneumothorax. Same thing can happen in constrictive pericarditis, restrictive cardiomyopathy. In all these cases, we will call it as obstructive shock. Blood volume is fine, left ventricular contractility is fine, heart rate is fine, but blood is not getting filled into the right side. It is not entering the right side. Or sometimes what happens is blood enters the right side, but then it is not able to go to the lungs because there is a massive clot sitting in the pulmonary artery. So if there is a massive clot sitting in the pulmonary artery, we call it as pulmonary embolism. So blood comes to the right side of the heart, but then it's not able to pass to go to the pulmonary capillaries. Thus, it is not able to go to the left side of the lung. Less filling of the left ventricle, less cardiac output. Less cardiac output means shock, right? So these we will call it as obstructive shock. So let us understand the pathophysiology of obstructive shock also. So what happens in obstructive shock? So two more types of shock. So first type of shock was hypovolemic, second was cardiogenic. Now we are talking about obstructive. So in obstructive shock, examples for this are cardiac tamponade, restrictive cardiomyopathy, then uh, chronic constrictive pericarditis, tension pneumothorax, and pulmonary embolism. So these are all causes for obstructive shock. So in these cases, what exactly happens? Either you mostly barring pulmonary embolism, in all other cases you have decreased right ventricular filling. So because of right ventricle getting less blood, you have decreased left ventricular filling, because LV filling is dependent on RV filling. So if that means you have decreased preload. Decreased preload results in decreased stroke volume. Decreased stroke volume means decreased cardiac output. Decreased cardiac output means you have decreased DO2. That means you have shock. And as usual, because there is decreased cardiac output, there will be activation of RAS and sympathetic nervous system. They will cause vasoconstriction, and by causing vasoconstriction, there will be increase in systemic vascular resistance. Increased systemic vascular resistance. So in obstructive shock, systemic vascular resistance will be increased, cardiac output will be less, because less blood came to right, so less goes to left, less gets ejected, low cardiac output. Now in obstructive shock patients, if I check their pulmonary capillary wedge pressure, is there any problem of pressure buildup in the pulmonary capillaries? No, the problem is on the right side, not on the left side. So I can have raised JVP or CVP, because right atrial pressure, right ventricular pressure will be high, like in cardiac tamponade, constrictive pericarditis and all. But pressure in the pulmonary capillary will remain normal. Pressure in the pulmonary capillary increases when ahead of it pulmonary vein pressure increases, ahead of it LA or LV pressure increases. So pulmonary capillary wedge pressure here will be normal, but CVP will certainly be increased, because the blood is not able to enter the right side of the heart, and because of that the right atrial pressure will be high. So key point here is to know that you have increased CVP, you have increased pulmonary capillary wedge pressure in cardiogenic shock, and all these three types of shock you have low cardiac output. But then I have one more type of shock, that is distributive. So what are the examples for distributive shock? So the examples for distributive shock are septic shock, one of the very, very common cause of shock. Septic shock. Okay, what else? Anaphylactic shock. And then neurogenic shock. So what exactly happens in these conditions? In all these conditions, there is decreased systemic vascular resistance. That's the beginning point. But why systemic vascular resistance is decreased? Let us take the example of neurogenic shock. Like you heard of very bad news. Suddenly someone heard a very bad news. They collapse. Doctors call it as vagal syncope, right? And because there is, in such cases, there may be decreased tissue delivery of oxygen, then we will call it as neurogenic shock. But why there is decreased tissue delivery? Why this person collapsed? So when we heard suddenly some bad news, it could be a psychological stressor or even a physical stressor, it will lead to sudden decrease in sympathetic nervous system activity and maybe increase in parasympathetic. Or even if parasympathetic doesn't increase, sympathetic decreased. And when sympathetic decreased, parasympathetic overactivity does happen, because generally there is a balance. And we know that sympathetic causes vasoconstriction. But what parasympathetic does? Vasodilatation. So now with parasympathetic overactivity, there will be vasodilatation, and a dilated blood vessel will give less resistance to the flow of blood. That's why we say decreased systemic vascular resistance. But once I have vasodilatation, now the issue is this will result in peripheral pooling of blood. Means all these dilated peripheral blood vessels will hold more blood. Peripheral pooling of blood. And because of this peripheral pooling of blood, there will be decrease in circulating blood volume. Let us say I had 5 liters of blood, but out of that 1 liter got pooled in those dilated peripheral blood vessels. And because of that, the effective circulating blood volume is now only 4 liter. And if less blood is reaching the heart, there will be decrease in preload. Decreased preload will result in decreased cardiac output, and decreased cardiac output will result in decreased tissue delivery of oxygen, and you have shock. But one thing is there, When this decreased cardiac output happens, there will be activation of RAS and sympathetic nervous system. Okay. Now, in these cases, the angiotensin may fail to counter the angiotensin 2 may fail to counter the vasodilatation caused by parasympathetic overactivity. Right. Similarly, in sepsis, there is production of inflammatory cytokines which are inducing vasodilatation. Angiotensin 2 may not be able to counter it. So vasodilatation will persist. But then sympathetic nervous system, this is important. So let me ignore, because angiotensin 2 generally fails to counter the vasodilatation. But sympathetic nervous system, this also fails to counter the vasodilatation, but it will go to the heart and increase the heart rate and increase the heart's contractility. So by doing so, it can result in increased cardiac output. So it will result in increase in the cardiac output. So this decreased cardiac output gets abolished. So cardiac output was low, but that gets improved by increased heart rate and increased cardiac contractility. So now this is one type of heart failure where you have high cardiac output, at least in initial stages, before the sympathetic nervous system fails to get the heart sufficiently activated. Till that fails, still it is active, it's going to give you more cardiac output, especially systolic BP increases, and because of the peripheral vasodilatation, diastolic BP will be low. So you get a condition where you have high cardiac output, high systolic BP, low diastolic BP, high pulse pressure, but still tissue delivery of oxygen is low. This type of shock is called as distributive shock. So in distributive shock, the most important thing is you will have low systemic vascular resistance, but the cardiac output will be increased by these compensatory changes. Nothing to do with the left side of the heart, there is no rise in pressure, so you will have normal pulmonary capillary wedge pressure, and CVP is usually normal as long as there is no hypovolemia, but many patients of sepsis often have hypovolemia, so in that case it may be decreased, but main thing is it's normal if it is pure non-hypovolemic distributive shock. Okay, so now tell me, how do I approach a case of shock when they present to me? This table is very, very important, especially for the MCQ based exam. Okay, MCQs can be asked on this, giving you the parameters and then asking you to identify which type of shock it is. Key points to remember is, in cardiogenic, you have increased pulmonary capillary wedge pressure. In obstructive, you have increased CVP, and in case of distributive, you have increased cardiac output, decreased systemic vascular resistance. Okay. Now in these patients of distributive shock, when I check their pulse, cardiac output is good, so pulse will be high, bounding pulse with high pulse pressure, and the peripheries, because cardiac output is good and blood vessels in the periphery are dilated, peripheries will be warm. On the other hand, in the other cases of shock, peripheries will be cold and clammy because cardiac output is low. So that's why whenever I have to approach a case of shock, first thing I should see is, if it is a case of shock, then I have to see what is happening to the peripheries and pulse. Peripheries and pulse. So if peripheries are cold and clammy and pulse is weak or thready pulse, that indicates there is low cardiac output. So in that case, it could be what? It could be either hypovolemic shock. Hypovolemic shock. Patient might have lost blood or lost fluid. Or other conditions of low cardiac output shocker, then it could be obstructive shock. So either you have cardiac tamponade or restrictive cardiomyopathy, pulmonary embolism, or it could be this cardiogenic shock, right? Like you might have had an MI or a valvular heart disease or an arrhythmia. So now you can investigate further. Like for cardiogenic shock, you might have to do an echocardiography, ECG and electrolyte profile, and the same investigations might pick up the obstructive shock. For hypovolemic shock, history might itself be evident. Like if it is acute GE case, then you know it is hypovolemic. If it is a shock encountered in a patient during operation theater procedures, you know it's the volume loss, blood loss. Trauma patient, you know it is hemorrhagic. So history and minimum investigations will take you to the diagnosis. So every time you suspect a shock, examine peripheries and pulse. Now let us talk about the management. How do I treat hypovolemic shock? IV fluids, so that the volume loss is countered, and if it is hemorrhagic particularly, we might have to consider blood transfusion, especially when hemoglobin is less than 7 grams per deciliter. Okay. How do I treat obstructive shock? Treat underlying cause. If there is cardiac tamponade, how do you treat? You can write that example in your answer sheet. If there is cardiac tamponade, we do pericardiocentesis, right? Treat underlying cause. If there is massive PE, we do thrombolysis. And if it is cardiogenic shock, how do I treat? If it is MI, then we have to go for PTCA or angioplasty or a thrombolysis, that is revascularization. And we can give inotropic agents, the ones that increase the force of contraction of the heart so that we can get better cardiac output. Inotropes. So what are the inotropes that we can use? An example I'm writing here is dopamine. Dopamine infusion can be started to get better cardiac output. But if the peripheries are warm, you have bounding pulse, and you have increased pulse pressure, all of this indicate that you have a high cardiac output shock, and we should be thinking about distributive shock. It indicates distributive shock. That could be anaphylactic shock, septic shock, or that could be neurogenic shock, right? From the history, we will be able to always conclude about the cause. Like after a bee sting or administration of drug, if patient has gotten into this state of warm shock, then it is anaphylactic shock. If it is a known case of some infection and then developed this shock, then it is septic shock, right? If it happened in a healthy individual after some shocking news, it is neurogenic shock. So most common cause for distributive shock being septic shock, I will tell you about the basic management of septic shock. So how do I treat a case of septic shock? IV fluids. Preferred fluid is normal saline or ringer lactate. We are using 30 ml per kg bolus followed by maintenance. This 30 ml per kg bolus over 3 hours. Okay. And then we also need to give antibiotics because this is septic shock, right? So that completes our learning of management of shock. So what you need to write, you don't have to write this pathophysiology per se, right? I just want you to be aware of the definition of shock, and then the classification. In the classification, as long as you are able to put this table, that's also enough. But like put one extra column and mention two causes for each subtype. And then here itself, you can put one more column and mention the treatment. The treatment is IV fluids. If it is treatment is going to be IV fluids, if it is IV fluids and transfusion, if it is hypovolemic, revascularization and inotropes like dopamine for cardiogenic. Obstructive, treat the underlying cause. Distributive, fluids, antibiotics, and supportive care, right? So that completes our discussion of sepsis, discussion of shock. Now let's talk about the next topic, that is ARDS. So what is ARDS? ARDS is defined as non-cardiogenic pulmonary edema. Means there is fluid in alveoli and lung interstitium, which is not because of a problem in the heart. Non-cardiogenic pulmonary edema due to a systemic or local insult. So the lungs have developed edema because of an insult or an injury, which could be systemic or local. Local means lung level or system level. Okay. Now, how do I recognize this as a case of ARDS? Because cardiogenic pulmonary edema is way more common. So to call it as ARDS, first thing I need is, see, basically what is happening is, okay, let me describe it as well. So now we know that we have these alveoli, pulmonary capillaries, pulmonary artery, and pulmonary vein. So oxygen exchange happens at the level of capillaries. Now, if I fill this alveoli with water, that is pulmonary edema. This could be because of increased pulmonary vein pressure, pulmonary capillary pressure, blood fluid leaking into the alveoli, then it is cardiogenic. So here, no problem with the heart, but still you have fluid in the alveoli. We'll discuss why it happens later. This fluid impairs the gas exchange. So the minimum thing you need for diagnosis is, if there is fluid, there will be less oxygen entering the blood. So you should have hypoxia. So the diagnostic criteria says that you need to have hypoxia. How do I define this hypoxia? So hypoxia here is defined as the PaO2 by FiO2 ratio. PaO2 by FiO2 ratio of less than 300. So normal is more than or equal to 400. So when it is less than 300, you can say that there is significant hypoxia. So we are not relying on SpO2 or PaO2 alone. We are looking at the ratio of amount of oxygen in inhaled air and how much oxygen we got in the blood. Okay, and we can assess the severity of ARDS based on this ratio itself. So if the ratio is 200 to 300, we will call it as mild ARDS. And if it is in the range of 100 to 200, we will call it as moderate. And if it is less than 100, we will call it as severe ARDS. Okay. Now this hypoxia is because of accumulation of fluid in the alveoli. I need proof for that. How do I get it? I do an X-ray and I should see bilateral pulmonary opacities on X-ray, or if you're doing ultrasound or CT scan, any other imaging, right? You can write on X-ray or imaging. Now, this is generally because of a systemic or local insult. So I have to also prove that there was an inciting event responsible for this. So there has to be a temporal correlation between insult, not the verbal insult, then all the medical students will get ARDS, insult and symptom development of less than 7 days. What do I mean by this? Let me elaborate on it. So let us say I got infection somewhere in the body. So that infection will result in formation of inflammatory cytokines. These inflammatory cytokines will go and cause damage to the alveoli. And because of that damage, there is accumulation of fluid in the alveoli. Who is responsible? The infection, wherever it is. Like let us say I have an abscess in the, that muscle abscess is the cause for inflammation. Inflammatory cytokines are the ones which are causing alveolar damage and have developed alveolar fluid accumulation. But then I should have a time-bound relationship between this infection and alveolar fluid accumulation. What if last year, sir, I had an abscess in my butt and now I'm having shortness of breath? Is it ARDS because of that last year's infection? No, there has to be just a 7 days or less than that gap between an insulting event or an inciting event and development of ARDS symptoms. Fourth, pulmonary edema can be, and in fact most commonly it is because of heart dysfunction. So we have to rule that out. We rule that out by normal echocardiography, or if you have done more advanced investigations like cardiac MRI, SPECT and all, they should be normal. Then you can call it as ARDS. So this point is helping you to rule out the cardiogenic cause for the pulmonary edema which is visible on the X-ray. This pulmonary edema has resulted in hypoxia, and this hypoxia is probably because of a systemic or local insult. So what is the basic pathophysiology of this ARDS? The pathophysiology of ARDS is like this. So you have an inciting event. Let us take the example of some road traffic accident and crush injuries, like limbs are crushed. And that crush injury has resulted in, inciting event has resulted in increased production of inflammatory cytokines. And these inflammatory cytokines like interleukin 1, interleukin 6, these will cause, because they now go to the blood and damage to type 1 alveolar cells or type 1 pneumocytes, and also accumulation of inflammatory fluid in alveoli. And because of this, Type 1 cells are damaged, and also type 1 cells are the ones which are responsible for gas exchange and accumulation of this fluid. That will result in hypoxia. This will result in hypoxia. And this inflammatory cytokines also inactivate surfactant, which is produced by type 2 cells. Type 2 cells are not directly damaged here, but surfactant got inactivated, so alveoli collapse. And this collapse of the alveoli also contribute to hypoxia. So that is how we are getting hypoxia. So now the edema that is visible on the X-ray is because of the accumulation of inflammatory fluid. It is contributing to hypoxia. The hypoxia or low PaO2 by FiO2 ratio that we are seeing, it is because of damage to type 1 pneumocytes, accumulation of fluid in alveoli which is interfering in gas exchange, and inactivation of surfactant which has resulted in collapse of the alveoli, right? And all of this happened because there was an inciting event which incited inflammation in the body. It could be in the lung or somewhere. It's like inflammatory cytokines have to be produced in large number to cause ARDS. Okay, so now we know the diagnostic criteria. Let us understand the causes and management. So when it comes to causes of ARDS, we will classify the causes into two broad categories: intrinsic and extrinsic. Intrinsic means related to lungs. The problem is inside the lung itself, and extrinsic means problem is outside lungs. So inside lungs, what all inflammation can happen? Pneumonia. So if I have pneumonia, let us say I have right lung pneumonia, that will incite inflammation. IL-1, IL-6 increase. Through blood, they will go to left lung also, and they will cause damage to their alveoli also. So both right and left lung now have pulmonary edema. So pneumonia, lung contusion, aspiration of corrosives or aspiration of gastric content. These are all intrinsic causes. Then extrinsic causes: polytrauma, crush injuries, sepsis. In sepsis, there is increased inflammatory cytokine formation. Then third, it could be transfusion related acute lung injury. So transfusion activates inflammatory cytokines. They go to the lungs and cause the damage to the alveoli, and rest of the things happen. So these are some important causes. Now coming to the management of ARDS. The patients of ARDS are at high risk of death, and that is because of hypoxia. If I have to counter the hypoxia, I have to overcome all these problems. The fluid in the alveoli has to be brought down. The collapsed alveoli need to be opened up, and further production of inflammatory cytokines should come down. So how can I make this come down? Treat the underlying cause. If I have sepsis, give antibiotics. Once the bacteria come down, inflammation comes down, further damage comes down. So treating underlying cause. Second, damaged type 1 pneumocytes will be eventually replaced by the type 2 cells. They will act as stem cells and repair, right? But at least quickly, I want to make this fluid get drained out and the collapsed alveoli open so that they can participate in the gas exchange. How can I make a collapsed alveoli open? Only by putting the patient on ventilator. So when it comes to the management of ARDS, step number 1, treat underlying cause. Step number 2, ventilator. And ventilator strategies is what the teachers are interested in knowing. Okay, so there are a lot of things in these ventilator strategies. Right now for a prof exam, especially for a written answer, you can't go through writing all of them. I will tell you the key points that you need to remember. You need to have low tidal volume, because higher tidal volume makes this collapsed alveoli open with brute force, and it will cause the damage to those alveoli. So low tidal volume. When do we call it as low tidal volume? When we keep the tidal volume approximately 6 ml per kg per breath. So each breath we are keeping the tidal volume of 6 ml per kg. And we need high PEEP. So high PEEP, low tidal volume strategy. So this helps. The high PEEP helps the alveoli not to collapse again. We want to open the alveoli by pushing active air into it. Then we want to maintain sufficient pressure in this alveoli so that it does not collapse back again. Collapsing, opening is not a good thing. That will cause more inflammation of the alveoli. Okay. And then you can consider giving diuretics, because diuretics will help drain out the alveolar fluids. Fourth thing I want you to write is no role of steroids. Though theoretically speaking, steroids should reduce the inflammation and reduce the further damage, but studies have not shown benefit, so there is no role of steroids, right? So if you write this much, your ARDS is complete. If you want to know ARDS in more detail, I already have a YouTube video on Reed Harrison series. You can go through that. Now that brings us to the next important question, that is sepsis. And whenever I ask what is sepsis, students say, sir, infection. No. So conceptual definition of sepsis is the dysregulated host immune response to infection resulting in organ dysfunction. So in simple words, sepsis is infection leading to organ dysfunction. So if I have even severe infection, but all of my organs are functioning fine, it's not sepsis. It's just infection. Now, some of you might comment and say, sir, infection of blood is sepsis. No, infection of blood, like bacteria present in blood, we call it as bacteremia, or general term septicemia, not sepsis. Fungus present in blood, we'll call it as fungemia. Virus present in blood, we'll call it as viremia. That's not equal to sepsis. When infection leads to organ dysfunction, we call it as sepsis. And we follow a well-established criteria for diagnosis of sepsis, which is infection. You have infection that could be either suspected or confirmed. Now the point to note here is, very important point indeed, why organ dysfunction is happening here. Same, it's like inflammatory cytokines are to be blamed. So when you have an infection, your immune system mounts unnecessary exaggerated inflammatory response. So like, let us say I have some degree of infection, so I should have appropriate degree of rise in inflammatory cytokines like IL-1, IL-6 and all. But if I have too much rise, that's what we can also call a cytokine storm. So these cytokines will not only damage the affected tissue, but they will start causing damage to multiple organs, and those organs fail and you have. Okay. So if I have infection, either suspected or confirmed, and then I have proof that organs are dysfunctional. That proof comes from acute rise in SOFA score by more than or equal to 2 points. So the SOFA score system, you can get it in the Google as well, is a scoring system where multiple organs are assessed. For each organ, there is a parameter used to assess whether this organ is functioning fine or not. For example, lungs, we are looking at PaO2 by FiO2. Yes, the same ratio that we were talking about when we spoke about ARDS. We're looking at it. So if it is low, then you know that lungs are dysfunctional. We are looking at BP, mean arterial pressure, when we are talking about cardiovascular function. We're talking about, so there is also assessment for the kidneys in terms of urine output and creatinine. We're also looking at the neurological function by looking at the GCS. So we're looking at all organs in this SOFA score. So now, does not mean that everyone has all the organs functioning normally. Like I may be a case of CKD. In that case, my creatinine will be high, urine output will be low. So my SOFA score is not going to be 0. It is already high. But from whatever high point, if the points jump by 2 more points, then you know that in presence of infection, this jump is equal to 7, right? So many books just mention infection plus SOFA 2 points. That's not exactly right. You need infection and acute rise in SOFA by 2 points because patients already might have organ dysfunction. Okay, so I'm not discussing the pathophysiology here because pathophysiology is simple. Infection leads to excessive inflammatory response. Inflammatory cytokines increase, they cause organ damage and the organ dysfunction, and then you have sepsis. Okay, then what is septic shock is a question. Septic shock. Septic shock refers to, it's a form of distributive shock as we know, right? The definition is suspected or confirmed infection plus mean arterial pressure less than or equal to 65 millimeters of mercury despite, means BP is low despite fluid resuscitation or increased serum lactate levels despite fluid resuscitation. Means you gave fluid, or like you gave fluid, still BP is low or serum lactate is high. Both indicate that BP low means there is circulatory failure, and if serum lactate is high means tissues are in anaerobic metabolism. Indirectly, tissue delivery of oxygen is low. Then we will call it as septic shock. Okay. Now, once I have shock, we know the diagnostic criteria. I need to follow the. So first, how am I going to manage it? So first one is antibiotics. Within 1 hour of presentation, right? Preferably try to draw culture before that, but if you can't, give antibiotics. Life is more important than your antibiotic sensitivity result. Give antibiotics. Antibiotics should be preferably broad spectrum. We have to take into account many factors, like what are the risk factors for a particular infection in a patient, what is the prevalence of resistant organisms in that locality, in that hospital, and then you choose an appropriate cocktail of antibiotics, which you will revise once the sensitivity report comes. Antibiotics within 1 hour. Second, fluid resuscitation. Fluid resuscitation is either you're using normal saline or other crystalloids, not colloids, and you're using that initially 30 ml per kg per hour for first 3 hours. 30 ml per kg overall for the first 3 hours. So that may be like, if I have, let us say, a 50 kg individual, now I'm having a sepsis and probably heading into septic shock, then I will require 30 ml per kg over first 3 hours. What do I mean by that? So 30 ml into 50 kg, it becomes 1.5 liters. So over 3 hours, I should give 1.5 liters. So that means roughly 500 ml per hour. Okay. Then if required, I have to go for inotropic support to increase the cardiac output. And inotropic support, or more precise word is not, we're not aiming to increase the cardiac output, is a distributive shock. Only in the late stages of septic shock, it becomes the low cardiac output shock. But we want to cause the vasoconstriction of these peripherally dilated blood vessels. That's a mechanism for the shock in these patients. So we might have to consider vasopressors. If fluid resuscitation fails to achieve a mean arterial pressure of more than or equal to 65 millimeters of mercury, and in that case, what are we using? The drug of choice or a vasopressor of choice is going to be noradrenaline. So when noradrenaline is not achieving the result, you can consider using adrenaline and dopamine, but noradrenaline is the drug of choice. And fourth, your organs may be failing, so you might have to consider organ support. Like if your kidney is failed, you might have to go for dialysis. If liver is failed, you might have to give the supportive care for liver, like measures to reduce ammonia, measures to like vitamin K to facilitate production of vitamin K dependent factors. All of that we might have to do, right? So this is the basic management of sepsis. The mainstay of treatment is antibiotics, fluids, if required vasopressors, and organ support, right? So I'm concluding here. This is a brief overview of the emergency medicine questions. We have done the YouTube videos on all these individual topics in detail for those who want to study in detail. If you're giving the exam in the nearby days, then just stick to what we have covered here. It is more than enough for you to write a 5 to 10 mark question, right? I'm signing off now. I'll see you in the next class. If I have missed any of your queries, ping me on the Instagram. You can give me 2 or 3 days time, because plenty of queries are still waiting. I will come back and answer your